All right, this is the beginning of our narrated PowerPoints, and please be patient with me as this is the first time that I've gotten to do this, so we'll get through this together. We're going to finish up Chapter 6, which we're going to talk about the hypersensitivity reactions, and then we'll do Chapter 7, 8, 9, 10, and then I have a presentation of stress and mental illness, which of course we all need right now. So in chapter 6, the beginning of the chapter, we talked about the adaptive immune response and everything that went on with that. In the last half of chapter 6, we're going to talk about the hypersensitivity reactions. In hypersensitivity, these are inappropriate immune responses to an antigen of some sort. We actually see that an individual who displays hypersensitivity to an organism or its product usually possesses some degree of immunity, otherwise they would not have the response. Many diseases are associated with the development of an acquired immunity without someone demonstrating a hypersensitivity reaction, and that's our normal response. So normally, a person develops an immune response only against foreign antigens, or as I call them again, non-self antigens, because the body has developed a tolerance to our own self antigens that are present in our cells and tissues. So normally, our system only responds to the non-self antigens without attacking our self antigens. There are four main types of hypersensitivity reactions, and these are all based upon what type of cell is involved or cells, what type of antibody is involved or not involved at all. The first three types are antibody-mediated hypersensitivities, and these all are immediate type reactions. In other words, the clinical signs, which are primarily signs of inflammation, will appear within a short period of time after exposure to the antigen. Type 1 hypersensitivity reactions primarily includes allergy conditions and anaphylaxis, and we'll talk about each one of these in turn. Type 2 hypersensitivity reactions are what's known as cytotoxic reactions. Type 3 are immune complex-driven hypersensitivity reactions. Cell-mediated hypersensitivity, or what we call delayed reactions, is classified as type 4. While types 1, 2, and 3 all involve antibodies, type 4 only involves T lymphocytes. These can also be classified by groups into allergies, which are inappropriate immune responses to an environmental antigen known as the allergen, an alloimmunity, which is an inappropriate response to beneficial foreign tissue, and autoimmunity, which of course is the response to our self-antigens. So, type 1 hypersensitivity reactions, as I said, are primarily going to be allergy and anaphylactic reactions. Again, these are immediate type reactions. They typically occur within seconds to only a few hours after exposure to the allergen. The sensitizing antigen circulates throughout the body, triggers widespread mediated release from IgE-coated mast cells and basophils. So the primary cell involved in type 1 hypersensitivity reaction is the mast cell. The antibody involved is the IgE that will be embedded into the cell wall of the mast cells and potentially the basophils. Because so many mast cells undergo degranulation so quickly, what we will find is that we get an extreme histamine release, and this will cause a severe fall in blood pressure, lead to cardiogenic shock, severe respiratory distress, and eventually could lead to death in anaphylaxis. So therefore, prompt treatment with epinephrine, other appropriate Agents such as antihistamines are very important in anaphylaxis. And if you've ever known anyone that has anaphylaxis, you will actually know that they usually carry an EpiPen. This is to reverse, hopefully, the cardiogenic shock, at least until we can get them to appropriate healthcare facilities. So most people that die from anaphylaxis actually die due to the severe cardiogenic shock and the rapid fall in blood pressure. The severe respiratory distress is primarily caused by swelling edema around the laryngeal area. This is actually a picture of urticaria, or what the common term is hives. So what we can see is, again, the inflammatory response found in these areas where we see histamine being released. And this typically will be a systemic response. So while this was a shellfish allergy, so the exposure was through the GI system, the clinical signs were seen all over the body in the skin. Here's a picture of an individual that looks normal. And here she is after exposure to whatever the allergen is in an anaphylactic reaction. And you can again see the severe edema, and this can occur in the laryngeal area, and this will cause the respiratory distress. If we get enough histamine release, however, the blood pressure rapidly falls due to all of the vasodilation caused by the histamine, and we will see cardiogenic shock and the heart can stop. Antihistamine drugs often relieve many of the symptomatic allergy reactions, and many of you that have seasonal allergies will know this because histamine is one of the main mediators released from these IgE-coated mast cells. Later contact with the same antigen can trigger the massive release of histamine and cause the related clinical manifestations of inflammation. So some good examples of type 1 hypersensitivity reactions. So hay fever, food allergies, allergies to any type of thing. So what could be an allergen? Well, anything could be an allergen. We can also see systemic responses such as to bee stings, drug allergies, or snake venom allergies. Some people are actually simply allergy prone, and these are people that have inherited the propensity to become allergic, and we call these atopic individuals. Again, allergens can be anything in the environment. So commonly, again, such things as plant pollens, food allergies, and pick a food. I can probably find somebody that's allergic to whatever food it is that you've picked. All sorts of venoms, drugs, penicillin, cephalosporin, erythromycin are kind of the three big antibiotics that we see allergies to. We can see, of course, allergies to animals, and it's not really the animals themselves, it is the epithelial cells, the dander. So, could someone actually be allergic to another person? And the answer is actually yes. They can be allergic to antigens found on that other individual's cells. So, it's fortunately fairly rare, however. Type 2 hypersensitivity reactions are what we call the cytotoxic reactions. These involve IgG and IgM antibodies, and primarily macrophages along with neutrophils. What we see with a cytotoxic reaction is the antibodies, either IgG or IgM, will combine with cell or tissue antigens, and this results in complement-mediated lysis of the cells or other membrane damage. I'm going to show you a picture of this here in just a moment. Some examples of type 2 hypersensitivity reactions include autoimmune hemolytic anemia, blood transfusion reactions where we give a mismatched blood type to a person, Rh hemolytic disease. This is erythroblastosis fetalis, where mom is Rh negative and the fetus is Rh positive, and certain types of glomerulonephritis within the kidneys. Type 3 hypersensitivity reactions are called immune complex reactions. These also involve IgG and IgM, but the primary cell here is going to be the neutrophil with possibly some macrophages. In this case, the antigen-antibody immune complex forms first, then is deposited into the tissues. This activates complement, and neutrophils will be attracted to the site by the complement proteins, and this results in the further tissue damage. Some examples of type 3 hypersensitivity reactions include rheumatoid arthritis, systemic lupus erythematosus, which is the poster child of all autoimmune diseases, and again, some forms of glomerulonephritis. Here's a picture of type 2 hypersensitivity reactions. So let me explain what's going on. First of all, we have the antigen, whatever that is, and typically this is a foreign antigen that is in the body fluids. The antigen settles onto the surface of normal cells, and oftentimes this will be in the blood vessel and endothelial cells. Antibodies made to this antigen see the antigen there and bind to the antigen bound to the normal cells. This activates complement. This attracts phagocytic cells, again, macrophages or neutrophils, and they actually then attack and destroy whatever this antigen-antibody complex is attached to, but unfortunately, that happens to be our own cells. So oftentimes in type 2 hypersensitivity reactions, what we're going to find is vasculitis and inflammation of the blood vessel walls. This is basically a form of opsonization of the antibody. In type 3 hypersensitivity reactions, however, what we find is that the antigen-antibody complex forms first in the body fluids. Some cases, the antigen and antibody form small immune complexes. These are fairly small and remain soluble in the body fluid or blood. Others can form large immune complexes like this thing right here, and oftentimes in our neutrophils we'll see these floating in the bloodstream and actually phagocytize them within the blood. The problem is some of them form intermediate sized immune complexes. These tend to precipitate out of solution and land again on blood vessel walls or other normal tissues. This again activates complement, and this causes then phagocytic cells to cause damage to the underlying tissue. And again, vasculitis is going to be the primary thing that we see. So type 2 and type 3 hypersensitivity reactions both can result in vasculitis or other tissue damage. It just depends on when the antigen-antibody complex form. In type 2, the antigen binds to the normal cell first, then the antibody binds. In type 3, the antigen-antibody complexes form first, then land on the normal tissue. Type 4 hypersensitivity reactions are delayed. We normally will not see any clinical signs until 24 to 72 hours after exposure of the antigen. The only thing involved here is going to be the T lymphocytes. So there are no antibodies involved in a type 4 hypersensitivity reaction. T lymphocytes will be sensitized and activated on the second contact with the same antigen. So basically these are going to be T memory cells. Lymphokines produced by the T lymphocytes then induce inflammation and activate macrophages, and we see signs of inflammation. Some examples of type 4 hypersensitivity reactions include tuberculosis, certain fungal and parasitic infections, contact dermatitis, and one of the best examples of type 4 is actually going to be something like poison ivy or poison oak, or heavy metals such as gold or silver. So here we have this picture. Here's our cytotoxic T cell, our T helper cell, and our activated macrophages. Between the MHC class 1s and the cytotoxic T cells, the class 2 MHCs and the helper T cells, and the activated macrophage, all of these will actually form damage and cause apostosis of the normal cells. This then results in the inflammatory response. Here's a really good example of a contact dermatitis. This was actually to a heavy metal, gold in this case, but this could be seen in anything like poison ivy, poison oak, poison sumac that we have in this area. And again, you can see that we have inflammatory response, but again, these usually do not show up for about 24 to 72 hours after contact with the antigen. Now, we need to talk about suppression of the immune response. Why would we ever want to suppress the immune response? Well, there are actually several reasons. One is to prevent undesirable effects. Can you get too much of an inflammatory response, especially in the hypersensitivity reactions? Well, absolutely. Why do you take an antihistamine when you have an allergy going on? To suppress the histamine effects of the inflammatory response. It may also be to prevent the response directed against the individual's own cells or tissue components in autoimmune diseases. Or it could be to suppress the immune system so that we don't get rejection of transplanted organs. We also will give a drug called Rogam to any mother who is Rh negative. What this drug does is actually suppresses the immune response so that the mother will not produce anti-Rh antibodies that would result in erythroblastosis fetalis or Rh hemolytic disease in infants. There are several immune suppressive agents. Certainly, if we want to just take out the entire immune system, we could simply irradiate the bone marrow. This will decrease or completely block all of the cells of the immune response. Typically, this is going to be something that is an extreme measure. Immunosuppressive drugs impede cell division or cell functions within the bone marrow, thereby decreasing the number of cells of the inflammatory response. One of the biggest types of drugs that we use for immune suppression is adrenocorticosteroid hormones, or cortisone, or cortisol. These suppress the inflammatory reaction, they will impair phagocytosis, and they inhibit protein synthesis. The reason that I do not use these very often is because of the last two. The big thing is, in impairing phagocytosis, we're going to slow the debridement process, and inhibiting protein synthesis, we're going to slow the healing process. So corticosteroids actually will slow healing in our process. We can also give gamma globulins or antibody preparations that contain potent antibodies that will prevent the body from responding to a corresponding antigen. This is actually what Rogam is. It basically destroys any anti-Rh antibodies that would be produced by the immune system of the mother to Rh positive protein cells of the fetus. So, autoantibodies. What are these? Autoantibodies are formed when a patient loses self-tolerance to their own self-antigens. Normally, our system recognizes our cells as self and tolerates self. In autoimmune diseases, this tolerance stops and we begin to form antibodies to our own self-antigens. These autoantibodies then may injure or even destroy the patient's own cells or tissue components in an inappropriate immune response, and this is autoimmunity. This picture actually shows, in the dark green here, sections of or actually shows the antibodies that are attached to pancreatic islet cells, and this is going to cause the destruction of those cells. So the pathogenesis of autoimmune disease really is not truly known. What causes us to lose the self-tolerance? Well, it could be that we get an alteration of our self-antigens in some way, causing them to become antigenic and provoking an immune response. We're not sure why this happens at all. Or, more likely, in some cases, formation of cross-reacting antibodies against foreign antigens that then also attack the patient's own antigens that are similar to the foreign antigens. A great example of this is actually streptococcal antigens. So when you get strep throat, your body produces an immune response to the streptococcus antigen. The problem is in certain patients, some of their antigens on the lining of the heart are very similar in size and shape to the streptococcal antigens. Therefore, the streptococcal antibodies will bind to those and cause damage to the lining of the heart. This results in rheumatic heart disease or rheumatic fever. Another big thing is that we now believe that autoimmunity may be caused by a defective regulation of the immune response by the regulatory T lymphocytes. And in fact, many people are now thinking that this may be one of the biggest causes for a lot of our autoimmune diseases. Can we cure autoimmune diseases? The answer is no. Can we treat them? We treat them symptomatically with corticosteroids or other cytotoxic drugs that target the immune cells. Some examples of autoimmune diseases, really the poster child of all autoimmune diseases is systemic lupus erythematosus. And I'll talk a little bit more about that here in a moment. This is a systemic manifestation in various organs because the patient literally becomes allergic, if you will, to their own DNA. Rheumatic heart disease or rheumatic fever. I just talked about with the streptococcal antigens causing a cross-reaction with normal antigens in the lining of the heart, as well as in certain joints. Certain glomerulonephritis, and this is inflammation in the renal glomerulus that will cause then kidney shutdown. Several autoimmune blood disorders will actually cause severe anemia, leukopenia, a decrease in the white cells, or thrombocytopenia, a decrease in platelet numbers. Thyroiditis, there is a form of this that is an autoimmune hypothyroidism. It's actually called Hashimoto's disease. And what happens in hypothyroidism is that the autoantibodies bind to the thyroid stimulating hormone receptors of the follicular cells in the thyroid gland, destroying the follicular cells. And those are the cells that produce thyroxine and triiodothyronine, T4 and T3 respectively. We also will see a diffuse toxic goiter autoimmune disease, and this is known as Graves' disease. And I'll talk a little bit more about Graves' disease in just a moment. Systemic lupus erythematosus, named because it typically does have multisystem inflammatory manifestations, so it's systemic. Lupus, because many lupus patients will develop this facial rash that looks like kind of a butterfly, or what most people thought it looked like for a long time was the wolf mask on the wolf face. So Canis lupus for the wolf. And then erythematosus, because we're going to be affecting the cardiovascular system and the red blood cells in many times. Autoantibodies are made against nucleic acids, so this includes both RNA and DNA, erythrocytes that typically will result in severe anemias, lymphocytes resulting in lymphopenias, coagulation proteins, so we have clotting issues, phospholipids, which are found, of course, in every cell membrane, and platelets. And then I put etc. because there can be many, many manifestations of systemic lupus. What we will see is deposition of circulating immune complexes containing the antibody against host DNA. Systemic lupus erythematosus is a type 3 hypersensitivity reaction. This picture actually shows a number of cells in mitosis, as well as the speckled pattern actually showing again antibodies attacking these cells. Lupus is most often first diagnosed in women in the 20 to 40-year-old category with Negroid ancestry. However, we have made diagnoses earlier than 20 and older than 40, and in the other races as well. There are 11 common findings that we see in systemic lupus. The facial rash, that is the rash that's across the face. Discoid rashes found anywhere else on the body. A photosensitivity up to and including such severe photosensitivity that it results in legal blindness. Oral or nasopharyngeal ulcerations, non-erosive arthritis, and this is the rheumatoid arthritis. In fact, most geneticists now believe that rheumatoid arthritis is actually a subset of lupus. That does not mean that every lupus patient will develop RA, and not every patient with RA will go on to develop a full-blown lupus. Serositis, so inflammation of the serous membrane, so you get pleuritis, pericarditis, peritonitis. Renal disorders, including glomerulonephritis or even renal disease or renal tubular disease. Neurological disorders, hematological disorders, primarily anemias, but you can see again leukopenias and thrombocytopenias. Immunological disorders, and one of the interesting things about many of the autoimmune diseases is that while your immune system is fighting your own cells, it tends to ignore foreign substances. And now we can actually recognize the presence of the anti-nuclear antibodies, or ANAs, in many of these patients. But lupus is a diagnosis of exclusion. That means we rule out everything else it could potentially be before we make a presumptive diagnosis of lupus. Normally we say that if you have at least 4 of these 11 common findings, either serially, so one right after the other, or simultaneously, this indicates a presumptive diagnosis of lupus. If the anti-nuclear antibodies are present in the patient, we can then make a definitive diagnosis. But not all lupus patients will demonstrate these at a particular time. Some other autoimmune disorders, Graves' disease, and this is the autoimmune hyperthyroidism. This affects the thyroid stimulating hormone receptors on those follicular cells of the thyroid gland, and this causes them to overproduce thyroxine and T3. Oftentimes the patient's thyroid will actually enlarge or undergo hypertrophy because of the increased workload. Addison's disease is an autoimmune hypoadrenocorticoism. This affects surface antigens in the adrenal cortex and decreases the amount of cortisone produced from the adrenal cortex. Vitiligo affects melanocytes, resulting in decreased melanin production within the skin. And myasthenia gravis actually affects the acetylcholine receptors at the neuromuscular junction, resulting in skeletal muscle weakness. This is a common appearance of a Graves' disease patient. So, besides having the enlarged thyroid or goiter, oftentimes they will have what we call exophthalmia, where the eyes look like they're bulging out. Other clinical signs of Graves' disease can be hyperactivity, weight loss, and other things that would be apparent with a hyperactive individual. Addison's disease has again a number of clinical signs. Oftentimes we will see hypoglycemia. We can see postural hypotension, so that when they stand up, they oftentimes their blood pressure will fall to the point of passing out. We can see weight loss. There's oftentimes a bronze pigmentation of the skin. They look like they have a really healthy tan, but they truly don't. We can see changes in the distribution of body hair. So women can get a more male pattern of body hair. Men can actually lose their male body hair pattern. Sometimes everyone will lose all their hair, including scalp hair. Sometimes they grow extra hair. GI disturbances and muscle weakness. In adrenal crises, they actually can see profound fatigue, dehydration, vascular collapse, renal shutdown, and decreased serum sodium levels while increasing serum potassium levels. These two will result in the muscle weakness that we see associated with Addison's disease. A famous person that had Addison's disease was actually John F. Kennedy. Oftentimes in historical photos, you will see him sitting in a rocking chair. It wasn't that he liked rocking so much, it was the fact that oftentimes if he stood up, he'd pass out because of the postural hypotension. The other thing is he often had that really good looking tan. It really wasn't a tan, it was the bronze pigmentation of Addison's disease. Vitiligo. Here we see again the loss of the pigmentation from the melanocytes. Sometimes this can move around with the white patches. Sometimes they'll stay. Sometimes they'll increase in size, decrease in size. So it doesn't have a real specific pattern to it. But you can actually see that again, there is a hypopigmentation due to the effects of the immune system against certain melanocytes. In myasthenia gravis, what we find is that in normal neuromuscular junction, acetylcholine from the nerve will move over the synaptic cleft and attach to the acetylcholine receptor. This will start the sodium and cause then muscle activation. In myasthenia gravis, we produce blocking autoantibodies. What these do is they bind to the acetylcholine receptors, thereby blocking acetylcholine's ability to bind and therefore causing decreased muscle activation. This results then in the muscle weakness that we see in myasthenia gravis. And just an interesting note, Sleepy of the Snow White and the Seven Dwarfs was supposedly based on a friend of Walt Disney's who actually had myasthenia gravis. And that's kind of the common thing that we see is kind of just this mopiness, and oftentimes they're very tired and just generalized muscle weakness. Crohn's disease. You've probably heard of Crohn's disease. This actually affects the digestive system and most prominently the large intestine, where it forms a severe colitis. Food can aggravate Crohn's disease, but this is primarily an autoimmune disease. Sorensen syndrome. Of all the people that have Sorensen syndrome, 90% of these patients will be middle-aged women. What Sorensen syndrome does is it involves destruction of the salivary and lacrimal glands by the immune system. So you wind up with inflammation in the oral cavity, in the epithelial tissues, ulcerations of the cornea, and something known as keratosis or dry eye syndrome. This is a picture of a large intestine opened up, so you're looking at the mucosal surface here. And certainly I hope you can appreciate the inflammatory response that's going on here in this colon. This is an eye from a Sorensen's patient, and you can hopefully kind of appreciate that the cornea looks almost kind of pitted here in the light, and it really appears kind of dry. This is because the tear film is decreasing. This can even result in something that we call uveitis, which is actually seen in the anterior chamber here of the eye. This is another common sign that we see in Sorensen syndrome. It's known as a furrowed tongue, and this is just simply because the oral cavity remains dry so often that the dorsal surface of the tongue literally dehydrates. Progressive systemic sclerosis or scleroderma is an autoimmune disease. It affects females more than males, about 3 to 1. And it's a chronic progressive disease of the connective tissue where excessive collagen fiber is deposited within the connective tissues. This primarily affects the skin, but may affect the GI system, cardiovascular system, kidneys, lungs, and musculoskeletal systems, as all of these also have a lot of connective tissues. And then autoimmune hemolytic anemia. This actually affects the erythrocytes because the immune system is destroying the patient's own red blood cells. This is a picture of scleroderma. You can see that the fingers are actually going to be deformed because of the excess collagen that is being deposited within the dermis of the skin. There's very little movement over the joints. This finger actually is bent that way because that's the way the collagen actually was laid down. So this can be a very devastating disease for a patient that has it. Autoimmune hemolytic anemia. Actually, within this picture, there are very few red blood cells overall. And then I'll point out cells that look like this, and this one, and this one, and this one, and there's another one, there's another one, there's one. These are known as schistocytes. And these are actually red blood cells that are being destroyed by the immune system. So as we get more and more of these schistocytes within the blood field, that means we have less and less red blood cells to carry oxygen. This is a hard disease for me to talk about actually because my last little dog, after she had had a surgery to remove a lipoma, actually developed autoimmune hemolytic anemia. When I took her into the clinic and measured her hematocrit of her blood, it was only 4%. Normal is somewhere around 45%. And even after 2 blood transfusions, we could not get it up over 8%. And unfortunately, this actually caused her demise because of the severe anemia that resulted from this autoimmune hemolytic anemia condition that resulted from the surgical procedure. Now, alloimmunity. This is the inappropriate immune response to beneficial foreign tissues, so transplants primarily. We can see 3 types of rejections with transplanted tissues. Hyperacute rejections are very uncommon as these occur immediately upon restoration of blood flow into the donated tissue. This would mean that the patient would have had to have had a previous exposure to the same antigens found on the donated tissue. The only time that I could think of this would be a situation that actually occurred with a former student of mine who'd had a kidney transplant from a sibling. She was in the process of chronically rejecting the kidney when that sibling was unfortunately killed in an automobile accident, and they gave her the sibling's second kidney. That rarely happens, and unfortunately, she did not have a hyperacute rejection. Acute rejections of transplanted tissues occur as a normal part of an as a normal part of the immune response. Normally, acute rejections occur within about 10 to 14 days after the donated tissue has been transplanted. Think about it. A primary immune response takes somewhere between 5 to 10 days to get all the activated T lymphocytes and B cells responding, and so that would be about the time that would be needed to then start destroying the transplanted tissue. What we hope for with transplants is a chronic rejection. Is that transplanted tissue foreign? Well, it is. What we want to try to do is slow down or try to eliminate as much of an immune response in the recipient as possible so that hopefully they can go for a very long period of time or maybe never reject the organ or tissue that's been transplanted. So when we talk about transplantation, we're looking at examples based upon the major histocompatibility complex compatibility between recipient and donor. We want to try to match the tissues as closely together as between the recipient and the donor. That's why we will typically look at genetic relatives. So an autotransplant or autograft is actually where we move tissue from one area on an individual's body to another area on the same individual. Very little chance of rejection as the tissue is already self. Isotransplants would be tissues transplanted between closely genetically related individuals. Our MHCs are actually genetically programmed, and so someone that carries similar genetics to ourselves typically will have very similar MHC compatibility. But sometimes not even a closely genetically related individual will match, and so we go into the general population. This is known as a homotransplant. In this case, homo meaning same, we're talking same species. So human to human, cat to cat, dog to dog. And then heterotransplant or xenograft, this is between different species. So here's a good example of an autograft, a skin graft. Let's say a patient has burns on their facial cheeks. We could actually take skin from their other cheek area and put it on their face. Oftentimes, so we don't have to take as large of a graft, we will use what we call a microtome and punch holes in the skin. This will then allow us to graft a larger area within the graft region. Here's the example. Each one of these little holes will fill in with granulation tissue, but because they're smaller, we actually will have less scar tissue overall than if we had to take a large section of skin from the donor site and then heal that area. Isografts, well, the best person to get a transplant from would be an identical twin, just as these two gentlemen are. And because they share the exact same genetics, their MHC compatibility should be very, very, very similar. It probably will not be identical, but it's going to be very, very close. Needless to say, not most or most of us don't have an identical twin. That's when we go out to siblings or parent to child, child to parent, those closely genetically related individuals. But sometimes we just simply go to the human population. This is a picture of a heart transplant that's being done. The first successful heart transplant, was done in 1961 in South Africa. The patient only lived somewhere between about 2 to 3 months after the transplant was done, but now we actually consider heart transplants to almost be routine surgeries. I have also posted under the narrated PowerPoints the video from which this picture was taken, and I would like for you to watch that as well. And then lastly, xenografts or heterotransplants between species of different species. And interestingly enough, there is one species that shares many of the similar MHC markers as humans, and that is our lowly pigs. These two piglets are actually from a group of pigs at the University of Missouri that are genetically engineered and cloned, and these are considered to be the first step toward growing animals for use in human organ transplants. These pigs have been genetically modified and cloned to produce even more of the human markers on the surface of their organs. So one day we may be able to actually call up to the university and say, hey, I need a heart for an infant, and by the way, send me the ribs and the side of bacon with some show me barbecue sauce. Now, someone may say, how do the pigs feel about it? And the question is, I don't know, or the answer is, I don't know. But if it was a choice between my child and the pig, unfortunately, I think the pig would not survive the choice. So these are a possibility. Historically, we have used porcine heart valves to replace mitral valves in humans for years, as well as bovine and horse valves. And we see actually less rejection with these animal valves than we do with the artificial valves overall. However, we're not quite to the point where we can do heart transplants or liver or lung transplants from these animals as of yet, but this might be a stopgap measure if we needed something such as that. And this is the end of this particular chapter. So if you have any questions, I am going to put up a discussion board over this chapter where you can help each other and ask and answer questions, and I will get in the discussion board as well, or you can certainly email me. And so I will leave you with this last picture. This is a naked mole rat, and what they did is they actually injected a synthetic model of the cartilage of a human ear. And this rat actually grew cartilage around that model, and now this can actually be transplanted to a human for the external ear. So we've been doing these xenotransplants for some time.